We welcome Ruth to the National Patient Organisation Network Australia Conference to provide an update to the community on her work and how we as a community can better support our rural and regional patients and families. Thank you, Dr. Stewart, Professor Stewart, and we look forward to hearing from you.
Hi, thank you. Now, is this sound working okay? I've just put these little headphones in because there's a dog in the background who's protecting my mother-in-law. Can you hear me okay?
We can hear you loud and clear.
Great, excellent. Okay, so I've got some slides prepared, so I'll share them. Okay. Sorry, wrong screen to share. There we go now, you're seeing. Yep, great. Okay, so I'd like to thank you for inviting me to talk to you today. I've like to begin by acknowledging the traditional custodians of the land on which I stand today. I'm on Wurundjeri Willam land of the people of the Greater Kulin Nation. I also acknowledge the traditional custodians of all the lands where we meet virtually. I pay my respects to the Wurundjeri Willam elders and the elders of your lands, past, present and emerging. And I extend that respect to Aboriginal and Torres Strait Islander people who are here with us today. So I'll just begin by giving you a quick rundown of what the role of the National Rural Health Commissioner is. It's to achieve the goals and priorities set by the Minister for Regional Health in a statement of expectations that has been published. It's a letter to me, but it's a public document. And that was handed down early last year, but it covers my activity from the 30th of June 2020 to 1st of July 2020 to 30th of June 2022. I have responded to that with a statement of intent, which describes how I intend to meet those expectations. And it begins with engaging with rural, regional and remote stakeholders and to ensure that a strong rural focus is maintained. Throughout my career, I've been conscious that in the rush to describe and respond to the health issues in our nation, the issues and how those issues affect rural and remote communities very quickly can be forgotten. Rural and remote residents make up 30% of the Australian community. That's not insignificant. And so their issues are not insignificant. So what's the actual work? My office likes to look at it like this. So we support urgent and emerging issues. Now, the major one of those, you'll no doubt have already guessed, is COVID-19. I'm called to support innovative models of care. It's fairly obvious that the models of care that we have in Australia at the moment are not meeting rural and remote people's needs. And we need to innovate and find models of care and business models that support those models of care that actually work in rural and remote Australia. We need to look hard at how we train the rural workforce, both the primary care reform and the people working within that primary care in rural and remote Australia. That gets summed up pretty much as rural generalism, both in medicine and nursing and allied health, and stakeholder engagement. I have been working hard with key professional organisations and have been exploring how best to engage with consumer advocates, and will soon be beginning a series of workshops working closely with the Consumer Health Forum of Australia to explore issues that are important in rural and remote health from the consumer point of view. I just want to put in a bit of a plug here. Yes, I've been a doctor for a long time, but I've lived all my life, apart from the time I spent for training in the city. And in the last decade, I have had some really serious health issues, and so has my husband. We were talking with a friend who we hadn't seen for a long time recently, and he looked at us, put his head on one side and said, "So what you're saying is if there hadn't been good care where you were, you'd both be dead by now." And I looked at him and went, "Yeah, you're right, actually. Yes." And so I'm acutely aware of the importance of strong healthcare systems in rural and remote Australia, both on a personal level, but also on an organisational level. So just to summarise, for those of you who are not aware of this, rural and remote Australians have poorer access to health services than regional or metropolitan Australians. There's limited or lack of local health services in many particularly remote communities. And rural Australians generally have a lower socioeconomic status than their urban compatriots. And there are long distances to travel. So if my community doesn't have a particular service, it's not a half-hour drive to access the nearest service. Quite often it can be many hours of driving or plane flights. So what is the impact of this poorer access to health services? Probably there are plenty of you in the audience who experience this on a day-to-day basis. But for those of you who don't, rural Australians have a shorter life expectancy. I moved from rural Victoria to far north Queensland, eventually to live for 6 years in the Torres Strait, and statistically speaking, I reduced my life expectancy by 20 years by doing so. And I am an educated white woman, 20 years lower life expectancy. I don't think my life expectancy should be determined by my postcode, but for most of Australia, it is. So poorer health outcomes, what does that mean? There's a heavier burden of disease and also a greater number of comorbidities. And there's an increase in potentially preventable hospitalisations. People don't get the care outside of the hospital to keep them well, so they end up getting sicker and having to be admitted to hospital with all of the disruption that entails. So in rural and remote health, we have difficulty attracting and retaining workforce. The workforce is unprepared for the complexity of rural practice. You can't just focus on one narrow specialty. You need to be a jack of all trades. We call it rural generalism. Healthcare systems can be very inflexible and really difficult to apply in small rural and remote communities. There's a lack of housing and services, so many healthcare professionals don't want to bring their families to these places. So rural generalism, I've mentioned it. It's like a one-stop shop for individuals and families. A rural generalist practitioner is connected to the community, both personally and professionally. They're much more likely to live in the community that they serve than somebody who is not a rural generalist. Their skill set is flexible and adaptive. They tailor their skill set to the service provision needs of their community. And they work as part of a multidisciplinary team. Often people describe this as them being the Swiss Army knife of health professionals. They can do everything, not as well as perhaps, you can see there's a set of scissors there. Yeah, you'll get better scissors, but when you're stuck without a pair of scissors, having the Swiss Army knife scissors can be a lifesaver. Rural generalists are like that. Rural generalists are trained to do the intervention, the immediate intervention, and keep people alive until the cavalry arrives, but also to manage the high frequency conditions. And it's community focused care. The National Rural Health Alliance is pushing this concept of rural area community controlled health organisation. They've taken a leaf from the Aboriginal community controlled health organisations that bring together strong multidisciplinary teams that are absolutely embedded and responsive to the culture of a certain community and that community's needs. There's local governance and service planning. They're adaptable to suit community needs, multidisciplinary teams, as I said, place-based models of healthcare delivery, and there's blended funding arrangements. So it's not a case of, oh, we need to go to this particular, we need to apply for primary health care funding, we need to apply for public health funding, we need to apply for ear, nose and throat. It's blended funding arrangements from both Commonwealth and state jurisdictions. So what do we mean by multidisciplinary healthcare teams? Now, sometimes when I'm talking to non-GP specialist colleagues, they think I'm talking maybe about a group of surgeons where you have a plastic surgeon and an orthopaedic surgeon and a a bowel surgeon. No, actually. Multidisciplinary healthcare teams that I and my rural colleagues refer to are integrated, coordinated of multi-professional groups so that they work closely together to assess and treat and support and follow up. So no one professional is working on their own doing all of that without the support of the other members of the team. Everybody's working together. There's a range of primary healthcare professionals providing the services. We know that this is associated with improved health outcomes and reduced hospital admissions. If we know this, why aren't we doing more of it? But it needs service planning and design tailored to community need. What can you do as consumers? You can seek an audience with rural peak bodies. You can request to attend conferences held by rural peak bodies. You can engage with rural health researchers. I heard Katie talking about this. You can note and question repeating patterns of activity. You can perhaps, if you find that every time, somebody who you're, either you yourself or somebody you're a carer for or somebody who's within your organisation presents the same dumb stuff happens, note that, record it, and take it to the highest levels of the health service and report on it. Write to the CE, Chief Executive Officer of the Health Service, write to the Health Minister, write to your local member. But particularly when you're doing that, you'll get much more response if you take your ideas on how things can be done better. When you're sitting there in the waiting room, when you're waiting between consults, when it's an hour between you having your x-ray and having anybody look at that x-ray and you're sitting waiting, you've got plenty of time to think. I bet you come up with lots of ideas on how this could be done better. Your point of view matters and can really make a difference. You just need to know where in the health system, which can be so opaque, and I understand that, where in the health system to take those suggestions. Look, I'm going to wrap it up there. Thank you. I'm very happy to take questions.
Thank you, Ruth. And that was a great overview. We do have a few questions, so I'm just going to try to turn my chat on. A really interesting question here from Andrew Giles. Are you aware of any hub and spoke models that work well? For example, if a rural generalist health professional was seeing someone with MS or Parkinson's or motor neuron disease, or shall I say MECFS, would they benefit from having a go-to metro clinic of disease-specific experts to refer to, perhaps via telehealth? And what do you see the role of telehealth as being in the models that you've described for us?
Okay, so look, it's really early days actually for a coordinated use of telehealth. We dusted off telehealth and brought it out during COVID to answer the very immediate problem of how do we maintain contact. The questions that really needed to be answered in that were, how do you get the highest quality interaction and connection between the health professional and the health consumer? And also, where's the best place for that to be occurring? Now, if you move all professional care to a specialist centre in the city, what can then happen is that say you're getting medication for your neurological disease, and there is a complication of that medication that affects you on a day-to-day basis, and you come and see your rural generalist GP. If your rural generalist GP is not closely involved in the decision-making about your neurological disease, they will not have upskilled to understand what the complications of what may be a very specialist medication are, and they may not even be aware of the fact that you're on that medication. So I see the role of specialist services in the city as doing the things that are complex, are complicated and specialist. Complexity is often the thing that rural generalists do best because of the broad scope. They understand that you are a person living in your community. They understand what your community is and what is possible in that community and what the pressures may be on you and your family and your extended community. The specialists may have no idea. I mean, look, the really common one is, here, have this blood test and come back next week. Look, I live, I'm not there at the moment. I'm heading back tomorrow morning. I live in Roma, which is 5.5 hours west of Brisbane. At the moment, the road between Roma and Brisbane is flooded in about 10 places. Just popping back to Brisbane to consult about a test result is ridiculous.
Yep.
And you might think, oh, yes, Ruth, you're exaggerating. I can tell you I am not. That just happens all the time. Test results reviewing can be very easily done by your local rural generalist. I think the things that we absolutely need our specialist consultant GP colleagues to do to formulate a management plan in collaboration with the rural journalist that the rural journalist then understands and can implement and understands what the parameters around it are. And you as a patient should not be the person expected to translate that from the consultant to your local GP. It doesn't make sense. I'm sure you've all had the experience of someone you know and love going to see a doctor, and you say, "So what happened?" "Oh," I said, I was okay." "All right, what about your liver function?" Or, "What about that thing on your toe?" "Oh, that was okay." But if you were in the room, you would have found that your loved one got a bit of a lecture about the thing on their toe and how they should be getting that dressed every week. But it wasn't a lecture they wanted to hear. That sort of thing. Mm-hmm. You need a whole team and not just an intermittent episodic. So that's how I see the role of specialist metro centres being to do the high level management plans and to work closely with the local rural journalists.
Thank you for that, Ruth. So we've got a little bit of time. I just wanted to ask you what you think our collective role as a network is. So we're a network of some very long-standing, experienced chronic disease organisations and some that are very small, representing relatively small numbers of people across Australia. As a collective, where do you think our voice is and how can we make a difference as a network?
Look, I think the first thing is to consult your members, find out who lives in rural and remote areas and what their issues are, and don't assume that everybody's issues are the same right across the nation. My experience is they're not, and the dominant voice will often be the one that's heard.
Yes.
And particularly with consumer groups where everybody's trying to play nice, and if you're feeling, if you're somewhat lacking in confidence and there's a very confident person using big long words talking, you might not feel that your observation or your experience is relevant to the whole. It's just as relevant. If you are a rural or remote person, your experience is just as relevant for your whole organisation as theirs is as an urban or metropolitan resident. I can get a bit heated and agitated about this because I'm a rural resident, and I get really cross when I hear people say, "Oh, you could just come back next week, or you can go and see your local paediatrician." I'm sorry, who? Where do you think we have them? Yeah. Anyway,
that's right. It's certainly my experience over many years has been, specialist support, and then let's not talk about the allied health support that, of course, is severely lacking, and that's where the strength of patient organisations across the country really comes in, whether that will be and is via telehealth, or whether it is through various regional supports and rural supports that many of our members already have, remains to be seen. But certainly specialist support and allied health support, and the mental health support for patients who experience this enormous sense of isolation and maybe even can't travel as a result of their condition is something that is of huge concern to many of our organisations who've been around for a while working in the challenging area of rural and remote health.
Look, I am particularly concerned to see the social determinants of health addressed for rural and remote communities.
Yes.
It's very simple: housing, clean water, housing, access to health services, access to education. Educate the women in your community and the health of that community improves dramatically. When you look at the average, I challenge you all to go and have a look at the census data for Australia. With each 100 kilometres you go from an urban centre, you find that the educational status of the community decreases.
Yep.
Any community that I've lived in, I'm just doing the maths here. I haven't checked with Roma, but any community I've lived in for the past 15 years, I have been the only person with a PhD, But I catch up with friends in the city, and in any gathering there might be 5 or 6 people with PhDs. And rural people are not dumb. They just don't have access to the education.
Yes, that's right. Well, Professor Stewart, thank you so much. Your lived experience as a rural health, a rural resident is a huge factor in how improvements can be made to rural and regional communities' quality of healthcare. We thank you very much for your very informative presentation, and look forward to being able to implement some of the recommendations that you've put forward. So thank you very much for joining us today.
Thank you very much for inviting me. I really feel privileged. Thank you. Bye.
Bye-bye.